I
You want to go Warsaw?
I'm gonna try for lab Monday. We ordered that like power adapter. It's supposed to be in tomorrow. It's pretty straightforward. It's like so I don't know. They haven't hasn't turned up yet. I haven't heard. So we should be able to have the iWorks unit hooked up. And I was reminded because we were in MCAT that I really need to do the eye and ear physiology nuggets because the other special senses are pretty straightforward, but the eye and ear nuggets we'll need to do
Also,
as
very
well.
quick to understand. You asked the class the question I posed to you.
What's that? Oh, go knock yourself out.
All right. Since he has the test scheduled for what, Monday the 12th?
Correct.
There's
13.
Can we move that to that Wednesday, only like 2 days later, because that Sunday's the Super Bowl?
probably not, honestly. Definitely Monday for sure.
He's being
This
sarcastic.
Monday is giving Monday vibes. Like, I'm feeling good about it.
It's always Monday.
I know.
Oh, good.
Definitely not a Wednesday.
If we go to trap, I'm saying I'm not studying the night before. I don't know how well I'm going to do.
How about we do it Friday and we make it online?
Good try.
No, not that good. But if we did it Monday online,
She's into that. She's an online. That we're going to hear that suggestion 4 different times.
Yeah, but
I'll give you mine.
Possibly the final. You may luck out on that.
I'm saying I don't care either way.
Can we do it the 15th?
That's what he's asking.
Yeah, but the
Well,
day
well,
before is
okay.
Valentine's Day.
Let us make a determination on that no later than Friday. You can lobby for your point of view
All right.
with those that are involved, and we'll get a
I would make a
consensus.
PowerPoint presentation, but I'm saying I think having it Wednesdays, we get more time to study, and it's better for everyone.
All right.
We're only 1 day later.
We've let enough air into this.
But let's be honest, who's actually studying than one day?
I will. He said this is almost as hard as anatomy, and I did terrible last week, so I'm actually studying. And I know I'm not studying Super Bowl Sunday, so.
It's nutty. I fail to see the interest in the game. I mean, it's just I don't have a rooting interest. All right, goodbye. All right, we're gonna start. Let's get ready to rumba. All right, here we are.
So is it?
That's Dancing with the Stars. Let's get ready to rumba. What?
Can you do that move again?
Yeah, let's get ready to rumba. My wife loves to dance. I officially have 2 left feet. So, nevertheless, here's where we left off. We're going to go back to the autonomic nervous system. Like I said, we're going to do special senses at the very least in lab, and hopefully I'll do that muscle experiment if we get the iWorks adapter in, and that's the plan of attack. So for here, from a lecture perspective, I want to do this and endocrine over that's the next, this will get finished either today or at the very latest Friday. So, and again, this is kind of where we left off. And the distinction again is between sympa and parasympathetic fibers. And the importance of this, where you're going to see in what it does, less about the anatomy of it, more about the effects of it that are there. And again, parasympathetic in general, the preganglionic fibers, they travel a long way, particularly highlighted by the vagus nerve, because that travels throughout your whole torso. And that's characteristic of it, as opposed to the relatively short postganglionic fibers. Once ganglia is very close to its end organ, and the opposite being true for the sympathetic, where the sympathetic chain of ganglia is paraspinal. It's right next to the spinal cord, though again, it's part of the peripheral nervous system. So you will see that and you'll see this illustration, and the highlight of this illustration is more about the differences. Not so much that we know that, the 3, 7, 9, and then 10 basically being all of this, with the exception for that sacral component of the parasympathetics, are this is all vagus nerve, and it's going effectively to nearly all of the internal viscera, the organs. The sacral division has much more about being genital and bladder related. Eye and salivary glands are very much what 3, 7, and 9, the cranial nerves are. Now, look over here. So here in the sympathetic division, the sympathetic chain of ganglia, even though it's not, they're trying to depict how close it is. And you can see none of it is cranial, sacral, and neither one has a cervical nerve component. But yes, we have the eye, we have salivary glands. Well, this, one will constrict the eye, this will dilate. Salivary glands, this will dry up, this will stimulate lungs, heart, stomach, pancreas, liver, and gallbladder. Notice some differences. Here, adrenal gland, and this is only the adrenal medulla. And that's what prolongs the effects in the bloodstream, as you will see by the release of epinephrine and norepinephrine, not as so much as neurotransmitters or at target organs, but throughout the bloodstream for prolonged effects. Yes, they both do bladder and genitals. Here, you can see the differences in skin, and the skin activation here has more to do with, limited bits of, effectively it makes your hair stand on end, probably more than anything else, I would think. And typically you will see an increase in perspiration for cooling. So the skin is a unique area, the adrenal medulla, and the most important area that's only sympathetic and it's extraordinarily important are blood vessels. The girth of your blood vessels, your blood pressure, effectively, and how the blood is distributed, whether you're is all about. That's what innervates the layers that either open or close blood vessels. And in doing so, not only does it redistribute the blood, but it also has very, very significant with regard to kidney function. Your kidney is an organ that's not under parasympathetic innervation. It's strictly under sympathetic innervation. So it will either allow the kidney to function or it will stop it. Because the kidneys are effectively a high pressure filter. If the blood pressure is not there, the filter does not work. We used to say in my own neighborhood, don't work. That's right. Lucky me, I'm a.
Oh, it's my sorority sweatshirt.
Okay. Yeah, I didn't make the end of it. Not a Steelers shirt, but then what is? Next time be the king. Good to be the king. I should get that.
Yeah.
Get that made up. It's good to be the king. Okay. Nevertheless, so here, and I'm not going to go through these. You can see them. They're going to go through them for you. Really, the most important part about this is what's coming up, is the discussion about fight or flight, and then the discussion about the different receptors and how these two systems work in a coordinated fashion. Is really what this is all about. So craniosacral, brain or sacral region, and again, it's fairly straightforward what they supply. Terminal ganglia are close to or even within target organs. Short postganglionic fibers, you saw that illustration. So to review, third cranial nerve is the oculomotor nerve, superior orbital fissure. What does it go? It involves in pupillary light reflex, constricting when there's too much light, opening it up to when there's an insufficient amount of light, and it also targets the ciliary ganglia because in doing that, as the muscle rotates, that sort of sphincteric muscle controlling the pupil, it will either stretch the suspensory ligaments in the eye that you'll remember and flatten the lens, or when it is constricted, that lens becomes more rounded. And what that therefore directs the light more accurately or refracts the light to the appropriate area to see for close or distant vision. Facial and glossopharyngeal, very similar because they're all about glands. Nasal, lacrimal, and as well as you can see the submandibular are all part of the facial. You don't have to know that it's the pterygopalatine or necessarily the submandibular. Just think glandular function, typically salivary, but lacrimal is also, and nasal for facial. And the glossopharyngeal, and again, you don't have to know the otic just meaning close to your ear, parotid, and that's really the major of that most of your saliva parotid gland. Parotid gland, and we'll get to that when we do digestive, is quite large. People get, interestingly, if there's going to be tumors, parotid gland is a favorite site. My mom had one, very frightened about it because when she was probably early 70s, I'm going to say, about the time that occurred. And it was very fortunate, it turned out to be a benign entity. I remember my sister and I both going down there because she was having surgery. And then 90% of all the preganglionic fibers, the vagus, the only cranial nerve that exits the head and neck area, thoracic and abdominal viscera. There's a variety of plexes, and really that's more anatomical, and I'm not that interested in it, that you have to know those things. But as you can see, it has a very, very, and then you get to the sacral, which is principally S2 and S4. Mostly pelvic organs, distal half of the large intestine. Splanchnic is a name that you'll see associated with gastrointestinal aspects that are there. Okay, and again, there's other plexes that are part of it. So you can see these ganglia, distal half of the large intestine, bladder, ureters, reproductive organs, be they male or female, of course. And you see the illustration, you see what it covers that are there. So we've got that taken care of. Sympathetic. More concentrated in the sense the ganglia are so close to. So some structures are innervated only, and this is the important, sweat glands, because in fight or flight, you're generating a tremendous amount of heat for cooling. Erector pili muscles, sort of coincidentally, that typically makes whatever you want to call it, your hair stand on end. And then smooth muscles for all blood vessels. You don't see a lot of all in the scientific word. This is an all. Okay. Sympathetic, also called thoracolumbar, I would say thoracodorsal, T1 roughly to L2. And you recall your spinal cord anatomy, you'll remember that in that area, we see usually just see ventral and dorsal horns. You see a sort of a point pointing directly laterally on either side of the gray matter. It's called the lateral horn. That's very, very characteristic of the nerves here. There's a lot of anatomy that I don't really do for this that are there, and that involves these rami communicantes, and it drives you crazy. We know what happens. You get branches from these fibers that, and some of them eventually will go dorsally, so it resembles a dorsal nerve, which you think is sensory, but really it's a motor branch that's going to some of the paravertebral musculature. And so here they give you all the different ganglia. And again, this is anatomical, so you don't have to know it. 3, 11, 4, 4, and 1, fine. And this is the chain. These are the sympathetic ganglia. You can see in reality extraordinarily close to the vertebral bodies and to the spinal cord. So, and years ago, because they controlled circulation, they did a thing, and I'm sure they don't do it anymore. We did a ton of them, never saw one that worked. They're called sympathectomies. And what they would do is they literally take out that chain. Let's say someone had a leg that was starting to have a chance to become gangrenous. And what the hope was, if you took that out, then without the sympathetic nerve, it would increase circulation. It would never work. And all those people eventually went on to amputation. I mean, this is a long time ago. So it was 45 years ago when I was seeing these things done by the vascular and chest surgeon who was doing it. But it was all of a sudden you make an incision here into the chest, and out came this chain ganglia. It was fascinating. I wish it worked, but it was fascinating. And so you can see these communicantes, these rami, which are just little branches that come together. And you can see what happens. They're discussing these so-called collateral ganglia. Not a big deal for us that are there. And again, whether they're non-myelinated or myelinated fibers, I don't really care about that. And again, innervate sweat glands, erector pili muscles, vascular smooth muscle via pathways to the head and the thorax. That's fine. So they're just showing it to you sort of in real life. But what happens is, yes, some of these nerve branches are going directly into the sweat and and erector pili structures that are there. So again, I don't get, you can see there's a lot of communication between them. That's that lateral horn that I was talking about, that little point that's there in those relevant areas of the spinal cord. So here we go. They identify these, and this is what they control in general. So the cervical ganglial area, roughly, so think of it T1 to T4, skin and blood vessels of the head, dilator muscles for the iris. So that's that same set of muscles that create the, just like we saw the parasympathetic with the pupillary light reflex, this is the reverse of it. Inhibit, again, sympathetic stimulation inhibits saliva formation, eyelid, some branches to the heart that are there. And then again, heart, thyroid, and lungs as we get into roughly now T1 through T6, those particular fibers. So they're just giving you an idea, the different structures that they innervate. Again, T5 to L2, again, greater and lesser and least splanchnic nerves, lumbar splanchnic, sacral. So you're going to see a lot more involvement with regard to intestinal smooth musculature that's there. And as you can see here, when they're looking at additional ones that are serviced by those same thing, aortic plexes, the celiac plexes, they used to call that the solar plexus, and it would have, that was a sympathetic plexus that was right under the xiphoid process. So directly underneath the termination, the inferior termination of breastbone. And that was like a blow that would really stun people because it affected so many sympathetics that were there. Nothing really there. So, I mean, this is more anatomical than anything else. So it's interesting in the pelvic area. Now we're down. Remember, this is just T1 through L2. T10 through L2, a variety of synapses that are there, a variety of other ganglia. Distal half, just like in the parasympathetic, distal half, large intestine, bladder, reproductive structures. Primarily inhibit activity of muscles and glands in the abdominal, pelvic, visceral organs. The bottom line is, again, when we reiterate all the events of fight or flight, in fight or flight, you inhibit digestive, genital, and urinary physiology activity. So you always know what it's going to do in those systems. The only time you're going to see change is when we see in sexual physiology, sexual response, about the being more of a stimulating effect that's there. And I'll come to that. This is really important. This is the adrenal medulla. And it's what's interesting about this particular, there's been some problems that have been associated with this, particularly with commercially available weight loss products. Okay? And they've been around forever, and they will continue to be around because everybody's looking for some magic pill that they can take and they can drop 20, 30, 50 pounds, whatever they can do. I mean, that's been what it's all about for such a long time. Okay, and we've been dealing with dietary, if you did not know, ever since the advent of, it came from Chinese tea called ephedra. So they would extract from a particular tea leaf a substance called ephedra. And that became the parent compound because they saw it reduced appetite, increased breathing. It was a sympathomimetic agent, something that stimulated the sympathetic nervous system. So it would decrease appetite, it would increase respiratory, it would increase alertness, it would dilate the respiratory passageways. So it has a vast range of sympathetic activity. They tinkered with it in the laboratory, and it became amphetamines. The first one was called Benzedrine. In the early days, in the 50s, you could get, now it's like what I have in my bag in the office because my ears are clogged now. I get one of those like steroid inhaler type things in your nose. They're available without a prescription, and they're very useful. My dad got one that was called a Benzedrex inhaler because he had the same kind of allergies that I did. It was a little piece of paper and a little plastic device that you put into your nose and you inhale. That paper was impregnated with Benzedrine. I didn't know my dad was a speed freak. Now he works 6.5 days a week. Maybe that tells you something. My dad's good. But he was always, first thing in the morning, Dad, I didn't know. And he chain smoked cigarettes and stuff. Everybody did back in those days. Now, he was born in 1914, so let's be clear about that. What came from that were, and then without prescription, people could get amphetamines for diet pills. And so people were getting those in the early 60s. And then as things went on with that particular, they began to see problems that were associated with them. And a lot of changes legally, roughly around 1970, where we began to see, which was really the Controlled Substance Act, came into play. Long story short, ever since then, pharmaceuticals have been making different things that contained ephedrine-like substances. I mean, the whole idea of why they banned something called Sudafed, now we use something called phenylephrine rather than pseudoephedrine, was because it would be used in meth labs to make speed, which if you were like me, a chemistry major, we knew how to make that stuff. It was a lot easier to make.
Breaking Bad.
And this is pre-Breaking Bad. I mean, that was it was a Beaker reaction major, something called phenylethyl ketone and hydrochloric acid. Just saying. Back in the 70s.
So you can make speed.
We could have, yes. Not now. You crazy?
What? Just a little accident.
Yeah, that was a lab. I knew chem majors who were making it. I was in college. You had to study. I mean, it's the truth. Look, guys, I don't know what it's like in your dormitories, nor do I want to know particularly what's going on in there. Okay, I remember a guy down the hall, he said, they called them greenies and black beauties, and those were the names. If you go back and look those things up, he had a sign on his door: greenies are in my top shelf, leave the money in the drawer. Like because we have exams periodically, what they call hourly exams, about 2 or 3 times a semester. It wasn't like people were hiding it.
What was this?
1970, 71. It was illegal, but it didn't stop
Did
anybody.
you try it or no?
Yes. It really helped when you were playing cards. I was a competitive bridge player, so I can remember
You're a
every
dog.
card that was played.
You gotta write a book about your life. Interesting.
It is interesting. It's not that interesting. Nobody who lived in the same time had this. They all had the same thing. My friend went to so many concerts, he could write a book about all the concerts he went to.
Any hearts explode?
No, I can't. We had some very strange events. Very strange. But I digress. It's okay. I was like, I should have like, I'm lucky I survived the 6. Nevertheless, why are people contacting me?
YouTube.
Moving on. So, what we see, and there were a number of these products, the most interesting story was a guy who played for the Vikings named Corey Stringer, who was an all-pro defensive tackle, 6'4", 370. They put him on a weight loss program, and it was turned out, and they were playing for the Vikings. They were training up like in Bemidji State up in Minnesota, and typically in summer, they had an unusually warm summer. They had him on an ephedrine-containing product that you could buy at GNC. He died, became hypothermic. And it has to do with the fact that it was triggering. What that would do is would trigger, and this is where the story comes from, epinephrine and norepinephrine, or adrenaline and noradrenaline, into his bloodstream. He became, when they were doing 2-a-days in pads, which is what they did, probably we're looking at maybe 20 years ago, 18, 20 years ago, happened. And that was in the summer. The next spring, they had an Orioles pitcher who died of the same thing in spring training down in Florida. His name escapes me. But so that, just to give you an idea. effectively the sympathetic ganglia, and this is the only ganglia that's really a long way away from the spinal cord, in the adrenal medulla in the interior. You're going to see the adrenal cortex is a totally different gland. It's a true endocrine gland. This is not. So it's considered, myself included, misplaced sympathetic ganglia. It's in here. This exterior portion, as you're going to see, is pure endocrine. The blood vessels surround it. They do not absorb the secretions from the cortical area. It's just the ones that go directly into the bloodstream from the adrenal medulla. And that's where it got its name, adrenaline, coming from there. Though it's only one of the several products that come from that area, this relatively small organ that sits on the top of the kidney. So the sensory nerves play a role. Chemical changes, stretch, temperature, irritation, mechanical or chemical inside, let's say, particularly in the GI tract. Free nerve endings, scattered cell bodies, dorsal root ganglia, the typical sensory ganglia, and the nerves that are there. Axons travel in the same nerves as autonomic motor fibers, okay? And they monitor conditions that are serviced by them. So they converge in the same second order neurons. Remember, we did first, second, and third order neurons. And so they play a role in referred pain. And referred pain, you may remember me commenting on that from some of the, I mean, that's the idea of when you have a kidney stone, like typically you feel that deep genital, particularly men, testicular or penile pain. Or at a heart, you have that left arm, that interior or medial left arm pain that's associated with it. And so, and they have reflexes, et cetera, et cetera. So a visceral reflex that empties the rectum or the bladder. But you got to go, you got to go. Enteric nervous system made up of sensory nerves, interneurons, motor neurons. And that's really what it does. That's there. You're getting the receptor, a stretch receptor, let's say in the case of the bladder. And, you know, at that point, that's your visceral receptor is going to have some type of effect. You know, obviously you might try to control your external sphincter to a certain amount of time until you obviously can no longer do it. The neurotransmitters, acetylcholine and norepinephrine, with the exception of the adrenal medulla, we call them by definition cholinergic fibers. They release cholinergic items. So they release epinephrine, norepinephrine. We refer to them as adrenergic fibers. All preganglionic axons, by definition, are cholinergic. All postganglionic fibers are of the parasympathetic, okay, are cholinergics, different kinds of receptors. The norepinephrine is released adrenergically with the exception of the sweat glands, which is the oddball of the sympathetic nervous system. The postganglionics are all norepinephrine, the exception of sweat glands, which are acetylcholine. That's an oddball to remember. So it's all about the different receptors. And then we saw this illustration before that are there and what they do. This is where the terminology is important. Depending on where you're going with your careers, you may run into terms like nicotinic and muscarinics. Certainly in a medical-based field you are. And they're named for substances that mimic their actions. Nicotine, before we knew about its addictive properties, it was a substance that was known in the laboratory. So prior to understanding the aspects of the nicotine addiction, we knew its usage, that there were nicotinic receptors, which were effectively all those ganglia, the synapses coming from the preganglionic nerves. Nicotine mimics those effects. And that's the interesting thing about people who smoke or people who use nicotine-based products, whether they vape or whatever. Since it triggers both sympathetics and parasympathetics, it can pep you up or it can calm you down, depending on the circumstance. Like, we all smoked excessively in medical school. Not all, but the vast majority of people. And I mean, before a test, you have a couple of cigarettes. After, to calm down, you have cigarettes. For me, I didn't really need an excuse. I liked it. Go figure. Muscarine is different. That's a poison that comes from certain kinds of mushrooms. I haven't been a member of the Western Pennsylvania Mushroom Society for 5 years, so I can't tell you what mushrooms it comes from. Moral of the story, Don't forage unless you know what you're doing. So I'm always on the hunt in the spring for morels. You know who knows a lot about mushrooms?
Or else are the good ones, right?
Morels are really good. And they grow around here. Dr. Dress knows a good deal. Nicotinic, all postganglionic neurons, hormone-producing cells of the adrenal medulla, so they are also nicotinic. Again, that's a preganglionic. Sarcolemma of skeletal muscles of the neuromuscular junction, by definition. So it's always stimulatory. They open ion channels, so they're rapid effects. The muscarinics all effector cells by postganglionic cholinergic fibers. Depends on what they are. The big issue is the exception. Binding of acetylcholine, as we'll get to when we look at the cardiac physiology, is the oddball. It doesn't increase the heart rate. It's what we call negatively chronotropic. It lowers the heart rate. Parasympathetic activity and what's known as parasympathetic tone is pivotal for heart health. Okay, binding to intestinal smooth muscle cells increase their motility. So your parasympathetics right now are very busy with regard to your gastrointestinal. So we classify them for adrenergics as alpha 1s, alpha 2s, beta 1s, 2s, and 3s. If you're going into a medical field, if you're going to go into a field that involves pharmacology, you're going to hear this stuff endlessly. This would be my recommendation if you're not. Whenever you're prescribed a medication, how it works. I mean, with the exception of, oh, this is an antibiotic, okay, fine. But if they're going to prescribe you a blood pressure medication, down the road, most likely you will be. Or an arthritis medicine or whatever it is, find out how it works. I would suggest being curious in that regard. So alpha 1s and alpha 2s, beta 1s, 2s, and 3s depend on which subcategory of receptor is involved. For instance, now, norepinephrine binding to cardiac beta 1 has major effects. It does two things. Yes, it's positively chronotropic. It raises the heart rate. Two, it's positively, we call it, I think it's inotropic. And that means that it increases the force of contraction. So if you think of what happens when somebody undergoes a cardiac arrest, one of the things that you have to do, as well as the defibrillating, you can only defibrillate it if there's a rhythm that's suitable, because that's when they inject epinephrine directly into the heart, because it immediately stimulates into the cardiac musculature. What it does is it creates a rhythm, whether it's abnormal or not. Once you have a rhythm, once it's beating to any extent, then you can shock it. If it's flatline, you can't. Shocking is not necessarily going to be a way. It might work, but not nearly as frequently as it will work otherwise. Okay, where epinephrine causes bronchial relaxation when bound to beta 2 receptors. The most famous and the ones you must know about beta 2 receptors, anybody you know who's on Ventolin or a similar substance or has an inhaler for their asthma, those are beta 2 agonists. They mimic the effects on beta 2. So that's, and we'll get into the fight or flight thing and review all of those things. I can't emphasize enough how important it is. That's the interesting one. And that plays a role, as you will see when we get into the effects of fight or flight. So fight or flight is an outpouring of initially norepinephrine and then subsequently epinephrine coming from the adrenal medulla. Okay, think of what it does. So it's any of these receptors are being targeted, whether they're alpha 1s or beta 1s, 2s, and 3s. So take a look. Here's the cholinergic node, beta 1s, heart predominantly. Also kidneys and adipose tissue. Increases heart rate and force of contraction. And what does it do? It stimulates the kidneys to release renin. Renin, and we're going to get to that in endocrine. Renin is a substance that's located in a particular area called the juxtaglomerular complex in the kidney that we've explored anatomically. Renin immediately starts to cause the transition of angiotensin into its active forms, angiotensin 1 and 2. It's known as the renin-angiotensin aldosterone mechanism, end product of which elevates blood pressure. Big player. So that's another thing to remember. B2, lungs and most other sympathetic target organs, abundant in blood vessels serving the heart, liver, and skeletal muscle. Mostly inhibitory. Dilates blood vessels and bronchioles, relaxes smooth muscle walls, digestive and urinary, so those systems are not active. Relaxes the uterus, again, those systems are not active. But what it's trying to do is maximize blood flow to the heart, skeletal muscle, and so too to the liver, because that's where energy sources are going to come. So it's fairly logical. So it's once you know what fight or flight does generically, you can sort of figure out, oh, what's it doing to the blood vessels and smooth skeletal muscle? Okay. What's it doing to the gastrointestinal genital urinary tract? B, adipose tissue, lipolysis, fat cells, energy source. Again, part of fight or flight. Alpha and alpha 1s and 2s. All sympathetic target organs, blood vessels of the skin, mucosa, abdominal viscera organs, kidneys and salivary, constricts blood vessels, sphincters, dilates pupils of the eyes. So what it's doing here is it's taking the blood flow away from those visceral structures because we want it to go to skeletal muscle and to the heart. And adrenergic axon terminals in the pancreas inhibits norepinephrine release from adrenergic terminals, inhibits insulin secretion. Insulin is useful when it's basically an agent that's part of the digestive process. When you eat something, inevitably, there's going to be some insulin release. How much is a question of what your diet consists of. Ketogenic diet limits that because you limit it's carbohydrate spared. Other than that, most of the time when you eat something, you're having a sandwich or a burger, insulin's coming out. And so and what's going to happen then, that's because your digestive system is designed to be active. We don't want that in fight or flight. That's not part of sympathetic. So there's a lot of logic behind these things. Moving on. Nicotinic agents, principally nicotine. Where do we see them now other than people who will continue to use them? Either smoking or vaping or using it. Most times they're smoking cessation products. There's a couple of categories of smoking cessation, but these are because nicotine doesn't work. It's degraded by stomach acid. It has to either be patches, okay, or gum, and the gum is absorbed through blood vessels in your gums. If you didn't know that, it does tend to make some sores. My trouble with that, the product that I used, his name is on the tip of my tongue, and I'll remember it. It was a pill that we took that had that basically blocks certain receptors. I don't recommend that. It worked great for me, but I'm telling you, that was the strangest thing I felt for 3 months. That was weird. I had to talk to myself driving. I told you, I'm driving the car going, make a right, get ready to make a right, make the right, make a left. And dreams at night, bad. But for 3 months, it worked. Okay. What happened with me, I got a better buzz when I smoked using nicotine patches. I'm sorry. I have to be honest with you. So that's how they work. So they're Chantix is the name of that medication. And I'm sure it's still used to it does work very well, but you really have to warn the people who are taking it. Okay. Smoking cessation, parasympathetics, muscarinic receptors, pilocarpine and botanicol, glaucoma. Open. So the idea of parasympathomimetic muscarinic agents is it's really useful for glaucoma, and we see these both typically these that are there. Okay. that you could use. There are other agents today. Most of the bladder problems, they had me on, I don't think they had it on botanical, but nowadays most of the people most of the urination problems, particularly in men, okay, are prostate related. And Flomax is a very effective product that doesn't have a lot of side effects. So before I had prostate surgery, which is about a year and a half ago almost, October of not like 21. Yeah, I think so. I mean, I had to use that constantly. Okay. Here's the ones that we've heard already about: acetylcholinesterase inhibitors. So for myasthenia gravis, absolutely, because that's because of the availability of the acetylcholine receptors are being autoimmune phenomena. Also, the one they don't, because they don't use it so much anymore, is that Aricept I told you about, that they were used for a short period of time for folks with Alzheimer's. So I have other medicines now, and then of course, similar to the insecticides, there's chemical warfare agents, acetylcholinesterase inhibitors. And here you get sympathomimetics and sympatholytics. The mimetics, the classic is albuterol, variety of trade names, dilates bronchioles binding to beta 2s. Phenylephrine, okay, is what we use now in place of the Sudafed, which is clearly a sympathomimetic. It just does not have, can't use that in the formulation in, home meth labs or, so that, and you can still get, I think, the Sudafed but you have to get it at the pharmacy window, and they take, because some people, the other stuff doesn't work nearly as effective. I did that for a while. There's a couple of products. Yeah, I used for that now I just use the phenylephrine. Okay. And sympatholytic. Again, these are in their common terms, mimetics and lytics. Lytic is a blocker or acts opposite. The early hypertension drugs, and the first one that we started to learn about that was used for when they treated high blood pressure, most of the time is fluid. It was based on using diuretics. Were clearly the standard that was used. They had the effects limited over time. So they started using propan. The problem with propanolol, by lowering what they were doing, they were blocking beta receptors, but it tended to slow down heart rate. And we had a lot of people fainting and those kinds of spells that were associated. It was also an early problem, one of the early reasons that caused a lot of erectile dysfunction. So people wouldn't take the medicine. So they changed the drugs, and we'll get into what they are. Because those are where we see a lot of calcium channel blockers and ones that work pathway. So here's the combination. We're almost done with this chapter, thankfully. Dual innervation. So antagonistic interaction, so it's a dynamic kind of antagonism. They oppose one another. And a lot of times it's cooperative. Very precise control. Sympathetic increases heart and respiratory, inhibits digestion, elimination. We talked about it. Parasympathetic decreases heart and respiratory, allows for digestion and discarding of waste. All blood vessel, almost all of them, is entirely sympathetic. So it's all about the blood pressure. There are some, I'm going to have to think of the limited examples. So we talk about the tone, continual state of partial constriction. There's tone in everything. This is just another one. Just like there's muscle tone that's constantly there and you have to account for. There is vasomotor tone. Vaso for vessel, motor for its muscular innervation. And so that's really what blood pressure is about. If blood pressure drops, most of the time your blood pressure, as we get into the blood pressure unit, is auto-controlled. You don't have to do a whole lot. You have a fairly wide range that we control yourselves based on fluid and circumstances, atmospheric conditions, etc. So if the pressure drops, fire faster. Pressure rises, they fire less. And it can move blood anywhere as it's needed. Parasympathetic, as you know, dominates all these other structures, heart, etc. Okay, so there's also a parasympathetic tone. In fight or flight, This is about how we understand it. This fight or flight is the closest thing to a pure override that we can see with regard to that. Drugs that block, what are known as parasympatholytics, increase heart rate, and at the same time, because you're limiting parasympathetic activity, you have urinary and fecal retention. So, let's see. Last one. We'll do this one here, and then I do want to review fight or flight next time we meet. Best example of cooperation, external genitalia. Parasympathetic, again, that is its major role is increasing blood supply, nitric oxide, penile, clitoral. Sympathetic fibers then lead to the ejaculation or climax phenomena, whether it's male or female, that are there. So that's probably the best example. That's why it's like Dr. Stephen Hawking was able to have kids biologically. A very famous line in that Eddie Redmayne won the Academy Award for. Different nervous system. Because you're paralyzed, you're in a wheelchair, you go different nervous system. And he lived a very long time with ALS, comparatively speaking. All right, we'll stop it here. We'll talk about the uniqueness, review fight or fight, and move on to endocrine. Thank you.